他的意识障碍的诊断和治疗。那么Olivia 是来自于比利时烈日团队，就是 Stephen Lawrence 团队的。那么他这几年也是非常的活跃。我们知道，在 Stephen Lawrence 的团队里边有很多很著名的研究者。那么在今年他的人员呢也有些流动。那么在这几年里边的 Gosseries 就是一个很重要的团队里边很重要的研究成员。他发表了很多相关的用行为评估及语言学技术来对他的临床的这种诊断进行研究。那么他也涉足到了很多的治疗。那么对于我们很多的临床医生来说，我们非常关注的是，我们做了诊断的预测之后，能够用什么好的干预方式能够帮病人获得进一步的提高。那么他在这个研究领域里边就比较偏重一些治疗。那么我们希望他的发言呢也能够帮助我们的临床医生呢能够获得一些临床的灵感那么下面请Olivia。
Hi everyone, thank you very much for the invitation. So today I would like to discuss diagnosis and therapies for disorders of consciousness. But before that, I would like to present you the team. So we are the Coma Science Group at the Giga Consciousness at the University of Liège in Belgium. And this group was founded by Professor Stephen Lawrence in 2007. And as you can see, it's a multidisciplinary team with a lot of people, including physicians, neuropsychologists, engineers and computer scientists, biologists, physical therapists, speech therapists, and nurses. And we all work together to better understand the brain, and especially the lesion brain, so after a coma. So today I would like to briefly introduce you the different disorders of consciousness, and then explain you how we assess patients at the bedside, and especially what we considered as a sign of consciousness. And then I would like to expose you how we can give a diagnosis of the level of consciousness using brain imaging and electrophysiology, and more particularly using transcranial magnetic stimulation combined with electroencephalography. And then I will finish by showing you what are the treatments that are currently available, and more specifically about brain stimulation and various pharmacological agents. So what do we mean by disorders of consciousness? So what happened after severe brain injury? So here you can see in this graph the recovery process of a patient who had a severe brain injury. And as you can see, there is parallel between the recovery of cognitive function and motor function up to a good recovery. So there are three things that we assess at the bedside when we see a patient. The first one is arousal. So it's the eye opening. Is the patient able to open the eyes spontaneously, or if we induce it with stimulation? And we see that if the patient is able to open the eyes, then the patient is no longer in coma, but transition into an unresponsive wakefulness syndrome, previously called vegetative states. And this is a patient who has eyes open, but only reflex movement. The second thing we assess is awareness. So is the patient conscious or not? And this, as we will see, it's a bit more complicated to evaluate at the bedside. So we are looking for non-reflex movement and behavior. And once we can see that a patient shows some sign of consciousness, then they evolve into a minimally conscious state. The third thing we are assessing once we know a patient is conscious is communication. Can we interact with the patient? And once we know how to interact and we have a functional communication, then the patient is no longer in a minimally conscious state. He has emerged from that state. So how do we do to assess consciousness at the bedside? So we look first at the behavior, and we have different kind of sign of consciousness that are established currently. So based on the coma recovery scale revised, which is the behavioral scale that we use to assess the level of consciousness in patients with disorders of consciousness, there are 11 items that are related to consciousness. And they are stated here in this graph. And as you can see, some behavior are more often observed in patients with minimally conscious states. And more specifically, we have 5 signs of consciousness that are more observed. The first one is response to commands. So that might be a response when we ask to close the eyes, to squeeze the hand, to look up. Then we have fixation, visual pursuit. So the patient is able to localize a person or a mirror in front of him or her. And then we have localization to noxious stimulation. So when the patient is able to localize the point of pain, of stimulation. And the last one is automatic motor responses. So that's, for instance, when the patient is able to touch the tracheotomy spontaneously, or grabbing the bed sheets, or scratching something in the face. So those 5 behaviors are the ones that are most often observed, and they can actually detect 99% of the patients in minimally conscious states. But then there's also other signs of consciousness that could be also taken into account when we do the diagnosis of the level of consciousness. So maybe you have some in mind, but recent research has suggested for a few. So here I will list them to you. The first one is resistance to eye opening. So this is when we have patients who have eye closed. If you try to open the eyes manually and you see that they resist like this, then we think that might be a sign of consciousness. Then we think of oral feeding. So, and specifically, if the oral phase is efficacious, like if when you swallow, you have the oral phase first. If this is efficient, then we also think that that can be a sign of consciousness based on the work of our speech therapist, Evelyn Mellott, in our group. Another sign of consciousness may be sound localization. So for now, auditory localization is not considered as a sign of consciousness in the Coma Recovery Scale Revised. However, we have here shown some evidence that it should be considered as a sign of consciousness. And this is the work of Manon Carrière in our group. And this is also based on the fact that other modalities, localization is a sign of consciousness. So if you think of visual pursuits or localization of pain. So we think that auditory localization should also be considered as a conscious behavior. Another one that has been suggested by the team of Paris with Nirlen Nakash is habituation of the auditory reflexes. So if you see that you have a decrease of this reflex, if you do it repetitively, this can also maybe be considered as a sign of consciousness. Then we have olfaction. So the fact that you respond to an olfactory stimulation, that might also be considered as a conscious behavior. And this is the work of the Israeli team, but also Aibo, Dee, and collaborator are also working on this currently. However, if you think of blinking to visual threat, this is not considered as a sign of consciousness, according to our previous and early work. So this should not be considered if you see that at the bedside. Another behavior that could be potentially associated with consciousness is when patients are able to do leg crossing. So this work by Remy and colleague has shown that it has an indication for prognosis or outcome, but here we could try to dig more into that behavior and see if somehow it could be also associated with consciousness. And then last but not least is the grimace. If you have grimace that are contextualized with the environment, this also may be considered as a sign of consciousness. So as you see, there are many different behaviors that could be associated with consciousness, and maybe you have others in mind, then I would be happy to discuss that with you. So what do the European Academy of Neurology recommend? So last year, we have had a consortium with many experts in disorders of consciousness, and this is the recommendation that we came up. The first one is to open the patient eyes. So if the patient is unable to open the eyes spontaneously or even with induced stimulation, then we really recommend to do the manual eyes opening, because that can also differentiate with, for instance, a patient who are in a locked-in syndrome. The second recommendation is to use a mirror when you want to assess the visual pursuit or visual fixation to assess the level of consciousness, because previous work has shown that more patients will follow their own eyes in a mirror than a person in the room. And then we also recommend to use the full outline of unresponsiveness in the intensive care instead of the Glasgow Coma Scale, because it's more sensitive to detect signs of consciousness, and especially the visual pursuit with a mirror. Then we also recommend to use the Coma Recovery Scale Revised, which is the most accurate scale, sensitive scale to evaluate patients with disorders of consciousness. And we also recommend to use it several times, repeatedly, because we have seen also that if you only do it once, you can have up to 40% of misdiagnosis. So it's really important to repeat the assessment, and we even recommend to do it at least 5 times within a short-term period, like 10 days. And then very recently, we also developed another scale that's called the SECONDS, the Simplified Evaluation of Consciousness Disorder. And this scale is obviously based on the Coma Recovery Scale Revised, but it's supposed to be easier to administer and faster. So as you can see here, we have first observation time, and then we look at response to comment, like in the Coma Recovery Scale, then the visual pursuit, the visual fixation, and also oriented movement. And then there are 2 facultatory items, communication and pain localization. And then we also look at arousal. So this scale is really faster to administer, and it's also easier, and there will be soon very specific guidelines with video to help you to use this scale. And what's also a very good thing in that scale is it gives you a diagnosis based on the score that you observed, as you can see here. So for instance, if you have a score of 1, the patient is in unresponsive states. And it also gives you an additional index score, so you can also track the evolution of the patient, even if it's the same diagnosis. So however, we know that doing diagnosis of consciousness at the bedside is very difficult. So that's why now we also do diagnosis based on neuroimaging. May that be using PET scan, fMRI, EEG, or TMS EEG. So here I will present you 2 case reports that, so it's 2 patients who came at our hospital in Belgium. And so here we have patient A. So we had her diagnosed as an unresponsive state. So we did many assessment with the Coma Recovery Scale Revised, and it was clearly that she was unresponsive. She only showed reflex movement. And then we did the neuroimaging, and this is the result. So what we see is, if you look at the brain metabolism with the positron emission tomography, you see that there is a massive hypometabolism in the whole brain, except here in the cerebellum, the brainstem, sorry, and the cerebellum, no, brainstem, sorry. For the resting state fMRI, so here we looked at the default mode network, and we see that there is no activation in this patient. We also looked at the diffusion tensor imaging, looking at the white track matter in the brain. And here you see that it's really severely impacted, with really a lot of loss around the whole brain. And we also looked at mental imagery task with the fMRI, and we asked motor motor task, and then a spatial task. And as you can see here, there is no activation at all. So in this case, we can see that the neuroimaging data confirm the diagnosis of unresponsive wakefulness syndrome that we observed at the bedside. And consider that this patient had been in that state for many years, that she was unresponsive, and she had an etiology with anoxia that we also discussed with the family, and the husband thought that she didn't want to remain in that state. Then in this case, we would discuss more about end-of-life decision. For instance, if the patient will have a pneumonia, maybe it's better not to treat the pneumonia and let her go. On the other side, we also have another patient who came at the hospital. She was at the bedside identical as patient A, so only showing reflex movements, so that lead to a diagnosis of unresponsive state. But you can see here that the pattern of neuroimaging is very different. First, we have relative preservation of the brain metabolism, as you can see here in red and green. We also see a partial preservation of the default mode network with the fMRI. We see that the structure of the brain is really good. And she also showed brain activation that was willfully done when we ask the mental imagery task. So in this case, we can refute the diagnosis of unresponsive states, because this pattern of activity really showed that she is conscious and she could even respond to commands using her brain activity. And for that, then the diagnosis that we would propose is minimally conscious state star, or we can also say, as Professor Schiff suggested, a cognitive motor dissociation. And in her case, then when we discuss with the family and the clinicians that are taking care of her, we would more suggest to increase the stimulation. May that be using like pharmacological agent, brain stimulation, or also just interaction and social interaction with that patient. So this is also a good case to show you that consciousness is really different from responsiveness. And so what we assess at the bedside is really responsiveness and not so consciousness for some patients. Okay, so then we have another technique that we use is the transcranial magnetic stimulation combined with electroencephalography. And this is a very promising technique, as you will see. So how does that work? First, you have a cap here that records the electrical activity of the brain. Then you have a TMS coil here that allows to send stimulation. And we also use the structural images of the patient to allow to really navigate correctly in the brain and to know exactly where we stimulate. We don't want to stimulate on brain lesions, so you have to stimulate on preserved or relatively preserved brain regions. So what the work has shown, and this is in collaboration with Professor Marcello Massimini at the University of Milan in Italy, is when someone is conscious, if you stimulate the brain, this is what happens. First, the brain will react locally where you had the stimulation, and then you see that it will goes everywhere in the brain, and the response will be widespread. You will have activation at the front of the brain, at the back of the brain, ipsilateral and contralateral sides, and this will last for approximately 300 or 400 milliseconds after the stimulation. What happens when you are unconscious? This is what happens. So here you see that the brain response after the stimulation is very different. It's like a slow wave sleep, like a response when you are sleeping, compared to here where you see it's more complex and it's more wavy. And what happened here is when you stimulate, well, yet you still see that there is a brain activation, but it remains local. And it's shorter. So you see after 180 milliseconds, nothing happens in the brain. So this is a very promising technique to assess the level of consciousness in patients who recover from coma. And here I would like to show you in one patient what it gives us. So here we have a patient who was after 35 days in a coma. She woke up and then we did the TMS-EEG assessment. And what you see here is we stimulate two brain areas, the parietal area and frontal area. And this is what you can observe as a response. So it's a slow, simple, and local response. Then a few days later, she recovered visual pursuit. So she entered into a minimally conscious state. However, the day of the assessment, you see that she came back into an unresponsive state. But we see that the brain activity is really different from the time she was unresponsive. Here, doing exactly the same experiment, we observe that we have a very different brain pattern activity with more complex responses depending on where you look at the brain, and it's also more widespread with the different colors. And finally, a few days later, she also recovered functional communication, so she emerged from the minimally conscious state, and you can see here a pattern that is similar to when she was in a minimally conscious state. So now we wanted to find a number that allows to give us the information if one patient is conscious or not. So that's we developed again in collaboration with the University of Milan and also in Brazil, the perturbational complexity index. So how does that work? So you use a zap technique, you zap the brain, and then you take the brain response, you compress the information, and you obtain a number between 0 and 1. And then you have PCI threshold that is at 0.31, meaning that if you have above this number, you are considered conscious, and if it's below, you are considered unconscious. And what we can see here in this graph is that we have like 7, 8 subjects that are conscious like you and me right now. And every time we stimulate, whatever the location and whatever the intensity of the stimulation, we have a high PCI. Then we had patients going into a non-REM sleep during the night, and we see that we have a drop of PCI compared to when they were awake. And similarly, if patients undergo anesthesia such as midazolam, xenon, and propofol, every time the PCI would also decrease. What about patients? So here we have also a couple of patients. We have the unresponsive patients who all have a low PCI under 0.3. Then we had patients in minimally conscious states, and they all have a higher PCI. And same for patients who emerge from the minimally conscious states, and same for patients who are in a locked-in syndrome. So this index is really reliable at the individual level. However, more recently, we have seen that in unresponsive patients, there are actually 3 kinds of responses. First could be a flat response, no response. So this is mostly related to when patients have an anoxia etiology. Then you have the majority of the patients who are unresponsive who will show this slow wave response that we have seen just before. But in some cases, like 15-20%, we have patients who actually show a complex brain response with a high PCI. And so we believe that those patients, they have the capacity to be conscious. And we also have shown that they may have predictive value, that the one who show that kind of response will recover later on, but this still needs to be confirmed. So what do the European Academy of Neurology recommend regarding electrophysiology? The first thing is to consider TMS-EEG to differentiate between unresponsive and minimally conscious patients, if you have the tools and the expertise. Then we could also recommend to consider quantitative high-density EEG measurement. But if you don't have this expertise or this measurement, then we highly recommend to at least look visually at the clinical EEG because it can have a high specificity. And finally, again, if it's possible, you could also look at the sleep EEG of patients, because if you detect some sleep spindle or K complex, then the patient might probably be in a minimally conscious state. Okay, the next and last section is about treatment. So we have seen a lot of things regarding the diagnosis, but how can we actually treat those patients? Unfortunately, there are not that many options available, and we still need to do a lot of work to improve treatment in those patients. So here I would like to list what are the current treatments that are available for patients. So first we have the pharmacological treatment, and more specifically dopamine agents like amantadine and apomorphine. We have also the zolpidem that acts on the GABA networks. And then regarding brain stimulation, we have top-down stimulation such as transcranial direct current stimulation, and Dr. Thibault already discussed this extensively with you. And we also have the repetitive transcranial magnetic stimulation. Then we have the bottom-up stimulation approach, and this is, for instance, a vagal nerve stimulation, vestibular stimulation, and spinal cord stimulation. And last, we have central stimulation, such as the deep brain stimulation and the low-intensity focused ultrasound pulse. And so we believe that all these different techniques can target different brain areas specifically or more widespread, and we have the mesocircuit model to explain how each treatment can restore consciousness in patients, and this is the work of Nicolas Schiff, who you also had the pleasure to hear today. So regarding the rTMS, so before I show you our TMS EEG, so for the diagnosis, we only stimulate and see how the brain reacts. So the point is not to affect at all the activity of the brain, but just to observe how the brain reacts to the stimulation. Here, using transcranial magnetic stimulation repeatedly, we really want to actually modify the brain activity. And doing so, preliminary evidence show that for motor stimulation, there is no change of behavior after motor stimulation using randomized controlled clinical trials. But there is preliminary evidence with open label studies that stimulating the prefrontal area or the parietal angular gyrus area may improve the behavior of patients with disorders of consciousness. And then we still need to assess other brain area and also like multi-site frontoparietal area. And one thing that we need also to check is that is it possible that patients who are minimally conscious will respond better to treatment than a patient in unresponsive states? This is the case for TDCS, for instance. Similarly, we need to see, is it possible that prefrontal area is a better target than any other brain area? And also to look at what parameters would be optimal. Regarding pharmacological treatment, we have the only one that has been recommended in the guideline in the United States by Giacchino and colleagues is amantadine, that has been shown to show a faster recovery than patients who had a placebo. But as you can see, after 2 weeks of washout, there is no such difference anymore. And then in a very early case report, we have shown that the improvement due to amantadine administration parallel improvement in the frontoparietal metabolism. The second treatment that we also try in every of our patients is zolpidem. So it's a sleeping pill. So it gives a paradoxical response. In 5% of our patients, they actually wake up from using the zolpidem. So some may be able to walk, to eat, to speak, but just for the time of the medication. And approximately 20% of the patient will also show some change in behavior, but not a change of diagnosis. And based on this study, we can see that what's different in the brain when the patient is with the zolpidem administration is an increase in brain metabolism in the frontal brain area. And we believe this is associated with attentional and motivational processes. And on that note, we actually don't know why only 5% or 20% react to the medication in a paradoxical way. And we think that it may be because of a genetic component, and so that everyone in the population would have this kind of side effect. So for that, we have developed an online survey for everyone. So please, when you have a little bit of time, just a few minutes, you can complete this survey to look for potential people who had zolpidem or not. Even if you didn't try zolpidem, you can still complete the survey. And I think in China, you use it as a zolpidem or Stilnox or Ambien, but also maybe Letan or Nuobin. So, but anyway, you can check out the link. And then the last treatment that we are currently testing in Belgium is apomorphine. And this is the work of Leandro Sand and Nicolas Lejeune, among other people. And we have preliminary results that are very encouraging. So this is also an avenue for treatment. So in conclusion, first of all, we have seen that consciousness is not the same as responsiveness, and that consciousness is related to the complexity of the brain. Then we have seen that it's important to use standardized scale, but also brain imaging to give a correct and appropriate diagnosis. And finally, we have seen a few therapeutic options, but there are still a lot of work to do, notably using and performing randomized controlled trials, but also to look for new treatments. And this will also be more easy to do once we know more about how the brain reacts, how do we do with the recovery at the brain level. And so we can use repurposed treatment, but also new treatment based on potentially new biomarker of consciousness recovery. And last, we also haven't discussed much about that, but all the ethical challenges that are around this topic and these patients and their family and the clinicians. And so I would like just to finish by don't judge a book by its cover. And actually, I'm not finished yet, because in our team, we also study near-death experiences after a coma, but also in other situations like in sleep or in meditation. So if any of you had any near-death experiences or know people who have had, please, you can contact us at this email, and we would be happy to hear your testimony. So thank you very much. And yeah, thank you again. I'll come back, I forgot my last slide. And so I would like again to thank you for your attention, and thank you all our fundings, patients, family, and the team of iBody and the team of everyone else. Thank you.
好的，感谢Olivia 的给我们的分享。那么在临床中间呢，他给我们梳理了一下，就是这些年我们在意识障碍的诊断以及治疗中间的一些主要的一些技术的进展。那么我们可以明显的感觉到，他在这个整个的系统中间呢，在 Steven Loris 这个团队里边开展的是比较完整的，而且我们的很多的中心实际上都是在跟随这个治疗的方法在实践基于我们的临床应用中。但是有一个我们也能感觉到，就是和前两位欧文以及Google 他讲的这些基础研究的发展进展里边，我们可以看到明显的临床的变化呢，并不是那么特别明显，因为相对于一些治疗的一些定型或者是应用呢，相对需要更长的临床的观察。那么在整个的过程中间呢，Olivia也这个特别强调了在2个指南，比如说2018年美国的 DOC 指南以及2020年欧洲的 DOC 诊断指南中间的提到的一些技术的指标。 那么我们也很欣喜的，就是在2020年，我们国内有赵继忠院士牵头的国内50多名专家一起写的慢性意识障碍中国专家共识总监，也大部分的体现了今天在这个演讲中间的一些技术的指标。所以说，在诊断以及治疗的理念上，我们现在基本上能够达到追赶，或者是和国际的同步，不管能不能实施，但是我们在技术的引进以及技术的了解上，都能够相对达到比较统一的一个标准。那么在他发言中间反复比较强调的几个印象深刻的几个点，第一个我们可以看到他在 PPT 的发言的首页以及在最后一页都强调了他的团队 group， 而且他也强调了对于慢性意识障碍这样的一个具有多学科特征的以及围绕多个症状进行处理的，需要有一个比较强大的多学科团队，这是非常重要的。我们知道在国内有很多单位开展是单一技术、单一科室的，如果是不协同其他的话，可能很难在技术上取得特别巨大的这种临床突破，所以要注意多技术的。在这个使用过程中间，他强调了在诊断技术中间使用的 TMS EG， 以及在TMS 或者是在刺激靶点的这种组合上也做了很多很好的介绍。这几年也都是在这方面的一些技术的进展，就是除了我们在近期的这种意识检测之外，还需要测定一下脑的这种反应性前面的几位讲者都强调了意识并不等于反应性，而对于这种病人的意识或者他的未来的预后或者诊断来说，反应性可能是一个更为重要的一个诊断的指标。好的，那么再次感谢